Welcome to Clinicals with PharmVic. Today, I will be talking about psoriasis. Plaque psoriasis is the most common form of this chronic inflammatory disease and classically affects elbows, knees, buttocks, and scalp. The choice of treatment depends on characteristics of the disease such as its severity and location, comorbidities including psoriatic arthritis, and response to previous therapy. Refer patients to a dermatologist if appropriate topical therapy fails, phototherapy or systemic treatment is needed, or if psoriasis is pustular, severe or extensive. Rationale for drug use: to induce remission, to reduce the severity and extent of psoriasis to a tolerable level, to relieve symptoms including itch and pain. Before starting treatment, minimize or eliminate potential triggers where possible, including stress, trauma, smoking, alcohol, infections. Streptococcal throat infection may precipitate guttate psoriasis. Drugs, for example, lithium, hydroxychloroquine, ACE inhibitors, beta blockers. Patients with psoriasis have an increased risk of cardiovascular disease and possibly metabolic syndrome compared with the general population. Manage cardiovascular risk factors and discourage smoking. Before starting treatment with immunosuppressants or cytokine modulators, consider presence of infection, including latent infection, for example, hepatitis B, tuberculosis, immunization requirements, especially for live vaccines, history of malignant disease. Topical treatment. This is used for most patients with mild to moderate plaque psoriasis and as an adjunct to phototherapy or systemic treatment in more severe psoriasis. Topical agents are commonly used in combination. Dates: moisturizers. This is a useful adjunct to other treatments as moisturizers hydrate the skin, soften scaling, and reduce itching and irritation. Encourage regular use of moisturizers, particularly after bathing or showering, to reduce water loss from the skin. Advise use of emollient soap substitutes or fragrance-free bath oils. Topical corticosteroids. Topical corticosteroids are a first-line option and can be used with other treatments. MATs. Choose the potency and formulation of corticosteroid product based on disease severity and location and on patient preference and age. For example, mild corticosteroids may be useful when treating face, flexures, and genitals. Psoriasis symptoms can worsen quickly after stopping topical corticosteroids, particularly when treatment is stopped abruptly. Calcipotriol. Calcipotriol has similar efficacy to potent or very potent corticosteroids. Calcipotriol is only available in combination with betamethasone. This combination is more effective than either agent alone. It can irritate particularly the face or flexures. Salicylic acid. This is keratolytic that reduces scaling and softens plaques. It is often used with other topical agents, such as coal tar, dithronol, and corticosteroids, as it allows them to penetrate lesions, increasing their efficacy. Coal tar, particularly used for psoriasis affecting the scalp, hands, and feet, can also be used for guttate psoriasis. Coal tar preparations can be messy, stain clothing, and smell unpleasant. They are also photosensitizing and may be irritant. Or dithronol. Dithronol is rarely used. It is irritant and stains clothing, skin, and hair. Avoid use on the face, flexures, and genitals. Phototherapy. UV light is used to reduce inflammation of the skin. Types of phototherapy include UVB therapy, using narrow or broadband UVB light, or photochemotherapy. Topical or oral methoxsalen with UVA light, PUVA. Treatment is generally given 2 or 3 times per week for a few months. Repeat treatment courses may be needed. Systemic treatment. Systemic treatment may be used for psoriasis that is severe or extensive, or for less severe psoriasis when topical therapy or phototherapy are inadequate or inappropriate. Methotrexate is an immunosuppressant used for severe psoriasis. Requires careful monitoring, particularly for myelosuppression and hepatotoxicity. Cyclosporin is an immunosuppressant used for severe psoriasis. Requires careful monitoring, particularly for nephrotoxicity and hypertension. Apremilast is an oral cytokine modulator which may reduce pro-inflammatory TNF-alpha and interleukin 17 and 23, and increase anti-inflammatory interleukin 10. It is used for psoriasis when treatment with methotrexate is inadequate or inappropriate. Acitretin is an oral retinoid used to treat severe psoriasis. For example, pustular or erythrodermic psoriasis or palm or sole psoriasis. Rarely used in women of childbearing potential due to risk of teratogenicity. Injectable cytokine modulators. Injectable cytokine modulators, often referred to as biologicals, are usually used for severe psoriasis when treatment with phototherapy, methotrexate, cyclosporin, acitretin, or apremilast is inadequate or inappropriate. Many also treat psoriatic arthritis. They target various pro-inflammatory cytokines that are involved in the pathogenesis of psoriasis. However, they can also cause immunosuppression and increase the risk of infection. They include interleukin inhibitors, guselkumab, ixekizumab, risankizumab, secukinumab, tildrakizumab, ustekinumab, TNF-alpha antagonists, adalimumab, certolizumab, etanercept, infliximab. Practice points. Consider pneumococcal and annual influenza vaccinations for patients taking immunosuppressants or cytokine modulators. Also, monitor patients for the development of psoriatic arthritis. Consider consulting a rheumatologist if suspected. If this lesson helped you, don't forget to hit that subscribe button. Please share this video. You never know who might need the right information to ace their exams or become more clinically sound. Let's grow together, learn, revise, and succeed.